Please start.
Bill Weintraub from Christiana. One thing I've learned at this meeting is get to the microphone early if you want to make a comment. So I want to return to the issue that Mitchell brought up about confounding by indication as we develop risk models, and I'll give an example. I'd like Michael in particular to I don't know. What do I do? Tilt it. Am I good?
That's better. Yes, thank you.
Okay. Okay. So I want to return to the issue of confounding by indication. I'll give an example, and that is revascularization, which we discussed at some length yesterday. If a patient with critical coronary disease is having a lot of angina, so he's going to be revascularized. And should he be revascularized with PCI or with coronary surgery? So we have options for options. One is we just look at the clinical trial data, and we look at the observational data, and we get our gestalt. Or we can develop risk models, which I'm in favor of. So what are the alternatives? One would be a risk model developed in a large cohort, which we have available on coronary surgery, and a large cohort which we have available on PCI, come up with risk models and compare them. And those are really the closest to our patient because they're going to really fit into that. But then there's the problem of confounding by indication. The next step, we could take observational studies like the one that you all have seen that I published, but also Mark Lackey's. You could take observational studies where we've done a really good job of developing propensity models, and within the structure of that, develop a risk model. And the final step would be to take the data from clinical trials, either the recent ones, if you like those, or take a meta-analysis of them and develop a model out of those. But then, of course, we have the problem. Well, those are highly selected patients, and even if we avoid confounding by indication, their event rates are going to be lower than we observe in the real world, even if we think we can match Renault covariates because of the reasons that patients were selected in the trials. So how do we resolve that? How do we go forward in developing good risk models? Question one. Question two, what are our best methods of assessing the quality of risk models? Should we look at discrimination, correlation, potential for reclassification? How do we decide when models are good ones?
So who would like to, Michael, you want to respond?
So on the first one, sure, confounding by indication is a nasty problem. I would love to work with more randomized trial data than I am at liberty to do. I just, by and large, don't have any. You'll never get surgeons and radiation oncologists to allow for that. They don't. There's very little randomized trials at that level going on in prostate, so I'm stuck with this. So on the diabetes example, the best thing I could think of to do was, because I am blessed with a large sample size and tons of events, and is to fit full models, listening to docs articulate why do they do what they do, what do you think matters, and take my best shot. Is that good enough? Good question. I don't know, but that's the only thing I can think of to.
Do you think the data may be misleading patient decisions?
It's possible. Is it worse than not doing that though? It's one of those issues. And how would you know?
And Nicholas, how about your method for trying to deal with the issue of, or the method you described for dealing with confounding by indication?
Yeah, so I mean, the method is a data mining method. My method is a data mining method. So it's not really for developing a precise risk model in any one setting. And that's kind of why I prefaced the talk by saying this isn't directly applicable, but these are maybe the types of technologies or methodologies that we could think about using for developing these types of risk models. As it is, I would not be confident enough that I corrected for confounding so well that I would trust the risk estimates that come out of it. And you'll notice that what I did, instead of saying, okay, here's a bunch of data mining, here I corrected for confounding, and here are all the results, is I try to corroborate those results with another data set. And I think that's essential, especially when you're using these confounded observational data sets, to continue to try and find maybe a complementary data set that you have some hypothesis or some feeling that it might have slightly different information, slightly different biases, and you can start to build up a kind of corpus of evidence that suggests that maybe your hypothesis is true. But it's a much more roundabout way. Obviously, RCTs are the way to go if you have, but if you have the money, essentially, and the amount of people. But when you start to study drug-drug interactions or comorbidity effects, then that quickly becomes infeasible. The number of patients you need is simply too large, and the costs are too large. So these technologies need to be investigated. The problem is we do not have a lot of validation that they produce reliable effect risk estimates. And so that's the challenge.
Dmitry,
Just,
you may want to respond to that, but also if you want to comment on the best methods for evaluating the quality of the predictions that are made.
quality of prediction. Well, there are books written on the best way to formulate models and on criteria for evaluating them, and I think very well established ways of checking how well calibrated the model is. In other words, does it, when it says 47%, is it near 47%? And also for deciding whether you can separate out people at very high risk from very low risk, the so-called discriminatory accuracy or area under the ROC curve. So I think some of the technical aspects of modeling have received a lot of attention and are continuing to receive attention, but there are adequate methods. I'm intrigued by the now if the clinical trial data are not available, then one has to use other sources of data, and maybe the prostate cancer area is a good example. And maybe we would have been a lot better off if there had been some randomized trials, by the way. You have to do the best with what you have, but that does mean, I think, some attention to why the person got a particular treatment as well as what treatment they got. But I think the observational data can add a lot, as Peter illustrated, in the context of a clinical trial. A clinical trial can give you an idea of what the effect of the treatment is, an unbiased estimate of the treatment effect, not only on the main outcome of interest, let's say prostate cancer recurrence or something like that, but also on other adverse events. The trouble with the trial is there are two problems with it. For extrapolating to the general population, one trouble is that you won't pick up a lot of the rare events, and that's why we need adverse reporting systems and so forth to look for the rare events. But the other is that if we're interested in absolute risk projections, the clinical trial may be too small to give you good, reliable baseline estimates of absolute risk. Getting at baseline estimates of absolute risk in the absence of intervention from observational data, when you multiply those by the relative risks, you're getting up to the absolute risk. Then you can begin to do a lot of things, and if you know about the distribution, the joint distribution of risk factors in the general population, again from observational studies, you can make a lot more valuable use of the clinical trial data on unbiased treatment effects.
Thank you, Bill. Thank you. Yeah.
Michael Pensina, Boston University and the Framingham Heart Study. I've been working on risk prediction for a number of years and methods of assessment. So I kind of want to give a couple of points from the cardiovascular perspective. Excellent talks, and in particular, I want to focus on Michael's slide where he presented this table with harms and benefits and the two drugs, because I think that's a very provocative and interesting goal for us to consider, but also challenging and controversial in some ways. Is that where we should be going? And in some level, the answer is yes, because if we know the probability of benefit, probability of harm, that's what every clinician would like to know. Then Mitch raised the issue of the confounding by indications. How do we get this information reliably? And then Peter raised the question, should we share that with patients? And I think that opens a lot of very, very interesting issues. Michael ended showing with the website potential of anybody programming their risk prediction model. And that's extremely controversial in my opinion. Like I review for a number of journals, and people produce risk prediction models, I think weekly, if not more often. We have a lot of them. Very few have been validated. You have companies that work for profit to use genetic information and so on to create risk prediction models. I've been in some conversations with the FDA, and the FDA is wondering, well, should we be monitoring this activity and to what extent? So I think it is essential that the models are validated and are reliable. So I come from Framingham, so that function was validated all over the world and is performing better in some populations, worse in others, but we know how it performs. So the big question is, how do we validate? Which metrics do we use? So the issue, there are a number of metrics, and I've done a fair amount of research in that area, and my answer is it almost doesn't matter as much which metric we use to assess model performance as it does whether we understand what they tell us and what are the standards for interpretation. What is good enough?
Good. Yeah, Michael, do you want to respond?
Yeah, no, it's a great point, and I do have to agree with that. So I'm selling guns on the street at some level, but or giving them away. Actually, they're giving them out, handing them out. I agree. You know, you'll never be able, even without that website type of thing, you can't stop it. And yes, I in some ways would be promoting that. The best answer I have to that, of course, is when obviously on our own site we're not going to list it until we're comfortable with the validation procedures and the error measures and stuff that we've done as best we know how to do. So they're not going to be listed on our page. They could be listed on the guy who made it and on his page, but you know, then it's a, you know, you can find all sorts of stuff on the internet. So it's gonna, we're careful in the language with our attorneys as to Cleveland Clinic not endorsing the prediction when it's yours, that's branded and stuff like that. But ideally, they're going to have a link to their publication that you or Doc, I guess, can go and read the paper first and make sure you buy into it and little things like that. But no, it's an issue.
Thank you. Let's move on to Jamie Robbins.
Other people have said a lot of what I was going to say, but I mean, so I just want to say about Nicholas's talk, which was kind of amazing, but you don't want to, there are qualitatively different things going on at this meeting. You got to keep straight. When I started epidemiology, everybody would talk about the story of vinyl chloride, where 3 workers from some factory walked into some doctor's office with some rare, I think it was liver tumor, and we said, you don't have to do epidemiology there. That's the, cause of whatever's in that factory. Now there's these incredible combinatorics, and so a human can't look through them all, and you need a sophisticated computer program to do it. I didn't understand the whole thing, but if they seem to do it cleverly, if I wanted to find one of those in a big data set, I would compare drugs with the other drugs like them and the diseases with other diseases like them. You'd have to do it in a clever way. And so you found one, it made a big splash. The question of I'm just curious, where are the 374 others that, why didn't you publish those? He wants to make a big, he's like everyone. How well does it really work, and how far down can you go before you start getting it wrong? One nice thing about what you're doing is you're not claiming to get it right. Unlike most data, you're just saying, go check this out, which is very different than what we've been talking about at this meeting, which can we use observational data to replace randomized trials? Well, it can certainly help, especially when the thing's off scale. And I was going to say the one thing you should do is make your algorithm and work with Patrick, that I just asked Patrick. See, this is what OMOP's good for. So you have a new algorithm. They have all these positive and negatives. Many of their positives are so little positive, I think, that I'd be amazed if, your algorithm did great. But even theirs, I remember, they do the best in they do the best in a sense I don't know if this is exactly true. They've already tried using another drug with the same indication in the same group as one of their controls. They're not doing it nearly as complicated. And I can't remember if it did best.
So why don't we let Nicholas
Okay,
respond? I
yeah.
think actually that last comment was right on target about having used another drug. I would also say that Jamie crossed a red line when he said that the meeting was about trying to decide whether observational studies could replace randomized trials. But we admire the provocative nature of that comment, and we'll let Nicholas respond.
Yeah, thank you for the comment, Jamie. So we are working with Patrick to kind of implement these methods and make them available. These are an ongoing process, so we're constantly trying to improve these models and make them better. And I don't think that, I feel strongly that using the other drugs that a patient is on can tell you a lot of information and can correct for a lot of confounding covariates. The problem is not every patient is on 6 drugs. And the more drugs they have, the more likely you are going to be able to correct. But for every patient that's on 1 drug, then we're up the creek. So you need more methods. This is not going to cover everything. And again, it's trying to support a new type of analysis. The EHRs and these observational data sets that have come available present an enormous opportunity to apply bioinformatics technology. And that's really what I'm excited about. And so that's kind of the first step in that direction, was figuring out a very simple yet marginally effective way to correct for this enormous problem of confounding by covariates.
So Bert, I wonder if you'd follow up, because as you mentioned in the introduction to Nicholas's presentation, this is a kind of data mining approach to trying to create approximate matches to patients based on a set of variables that are in the database. And how do you think that addresses the concerns that, or the approach that you were suggesting at the outset? And you have to hit your microphone.
Well, I think my view of what Nick had done, I think it's actually a good start in the direction of creating these matches. I mean, he didn't discuss to my mind, important aspect of getting at longitudinal information, but I don't see that that's necessarily a major obstacle. I think that's part of a research activity connected up with the informatics machinery, or at least as I see it, that's a direction you would be going. So I really think it's actually right in concert with, or at least a step in the direction of creating approximate matches and being able to mine large databases to get what you would call trustworthy approximate matches. Good. I don't know if that's
Also, just a quick comment. For validating, you're right. Like going down that list, Jamie, it's going to drop really fast. There are some more, just to let you know, the top 5 are pretty high confidence, and a few of the others are known to cause hyperglycemia, either individually or in combination, or exacerbated by the combination. But the way to evaluate that is to go into model organisms or identify a patient cohort and then examine that prospectively. And the idea is make your hypothesis from your data mining so specific and so strong that it's actually very easy to prospectively test. And if you can make them very specific and small like that, then we have an opportunity to really estimate, to validate them, and then estimate our actual performance.
So to be sure that we can get as many questions as possible, brief questions, relatively brief answers. Hold your thought, because there are other related topics we need to come back to. David.
Thanks. David Kent from Tufts. I just have a couple of comments. First of all, excellent panel. I want to pick up on what one slide Mike showed, where he showed that the gestalt of physicians doesn't agree. I just want to see if he agrees that it's also true that prediction models frequently don't agree, and even accurate prediction models will often disagree surprisingly a lot, and they'll lead to different recommendations, and sometimes it's just hard to tell which model is better, even though we're getting different answers. And that kind of underscores something Mitch pointed out, is that you shouldn't be comparing predictions from 2 different models to make any kind of estimate of treatment effect. So I think
and you've got a great paper on that, by the way. It's a problem.
Thanks.
I mean,
So,
Okay.
so the point that Mitch made of using risk models within clinical trials is, I think, a very good point, and that's one of the things that we've been examining. One of the things we've been finding is that there's a surprising degree of risk variation even in efficacy trials. So if you just describe what the risk distributions in some trials look like, you'll see, if you look at the extreme quartiles of risk, you'll see differences that might be tenfold. And when you see tenfold differences in the risk of the primary outcome, then that's not infrequently very clinically significant in terms of how it leverages into clinical decision making. And the other interesting point about looking at these risk distributions is that you could also compare the risk in the typical patient to the summary effect in the overall result. And sometimes you'll see that they don't match up, that the typical patient has typically a much lower risk than the summary result. It's a right skewed distribution because you can't, it's bounded at zero, obviously. You can't have a risk less than zero, but you could have a risk much, much higher than the average, which is in these low outcome rate trials. Typically, the average risk will be lower. The typical risk, the median risk, will be lower than the average. And so the average result can be misleading.
Thank you, David. Peter, do you want to make a comment?
Yeah, sure. I think the issue, the doctor bashing aside, the issue of understanding the users is vitally important, and I think, ripe area for investigation. And doctors and their understanding of risk predictions, something, since the support trial we've been sort of grappling with, when doctors sort of misunderstood 95% probabilities of bad outcomes equating to 100%. But same side, on the other side, researchers misunderstanding basic things about distributions of events and misclassifying those and mischaracterizing doctors as even worse predictors than they are. So I think we have to understand this continuum, and that's the only way we'll get over the thing that I face every day, Michael I'm sure faces as well, when doctors respond by saying, I don't treat populations, I treat patients. And so population-based numbers don't help me.
Hal?
Hal Sox from Dartmouth. So far, you've been talking mostly about prediction rules for prognosis, and I wanted to talk very briefly about prediction rules for estimating pretest probability and a bias that can happen there. Several lives ago, I developed a clinical prediction rule for estimating the outcome of a coronary angiogram. And so you have a chest pain score and a prevalence of disease corresponding to a particular chest pain score. We then applied it to another angio population and got the same prevalence. And then we applied it to two primary care populations with lower probabilities of coronary disease. And you guessed it, the probabilities were much, much lower. And when we then adjusted the probability estimates for the overall prevalence of disease using Bayes' theorem, things snapped right into line. So that's another example where confounding really by disease prevalence. And it leads to the interesting conundrum. A particular history in a primary care population means something very different than one with a higher overall prevalence of disease, which is kind of existential, I thought. So that's my comment. My question really for Michael is, Michael, why can't you do some cross-validation of your rules on the fly? Seems to me that you could at least provide some assurance about that error rate in estimating probabilities.
Yeah, so that's going on. There's all sorts of cross-validation going on in the modeling phase of that, and looking at the performance of the models. You mean on the fly with the end user obtaining the prediction?
No.
Or do you mean in the model building? Certainly it's going on in the model building in terms of getting optimism corrected, concordance indices and IDI, NRI, and all that good stuff. So definitely going on there. It's because I don't have the luxury of too many other data sets. But
Thank you.
Patrick?
So thank you for the panel. This has been a great conversation. My question's specifically for Michael. If I heard you...
There are other people up here, by the way.
So keying off a comment you made, I just want to make sure I understood it correctly. You said job number one is predictive accuracy. So goal is maximize AUC. or maximize some measure of predictive accuracy. I also heard you say that part of the model building is to use the clinical gestalt to identify the variables that would go in. We also saw the gestalt might be questionable. We also know that you're building models off of an EHR that has tens of thousands of features about patients, of which the clinicians might identify a couple. So I guess my question is Gestalt the right place to start for building a model, or should we be using the features in the EHR and just figure out whatever model actually gets us the best discrimination?
That's a fabulous one. I follow the Frank Harrell dogma on that, and just so I do use clinician judgment for the predictors and identifying the predictors, and then I don't do variable selection after that and fit full models whenever I can afford to do that. So I think the Gestalt's okay for that personally. It's the putting the pieces together in the optimal fashion where presumably it breaks down, but that's the best source, because they do understand I think, as well as anybody else, or better than anyone else, the nature of the disease process. And so I would look to them for the particular features I should be looking at. I think it's controversial in terms of the fishing for the predictors in the data in Epic or something like that, and winding up with stuff that shouldn't really be there. So I personally tend not to do that.
Have you contrasted the models using both approaches?
No, it's as he describes it, which I'm just following with it, but I endorse it. It's a philosophical argument about a performance in the future patient, an unknowable thing.
Sandy?
Yeah, a couple, Sandy Schwartz and Penn, a couple thoughts. 35 years ago when I started doing predictive modeling, and I've come back to it a couple times when it's been useful. And I wanted to give just a couple observations and get your reactions. The first is, I think it's really important to distinguish between the clinical objective. Is the objective to identify risk? Is it to inform the doctor and the patient about alternative trade-offs of prognosis or alternative trade-offs of treatment? And I think Mike's slide, which showed not just the left side column, but the right side columns that showed those things for different treatments is very important from a clinical perspective. But I don't think, where I disagree with what I think most has been discussed here, I don't think that accuracy, however you want to define it, and I wouldn't define it with an ROC curve, because everybody in the panel knows that the more continuous outcome you have, the more information content you have from any diagnostic information. I think we should think about it in terms of clinical utility, especially if we're talking about this within the context of PCORI and a patient and a learning healthcare system. So not all errors and correct answers are equally important. There may be a greater risk, a greater cost, not economic cost, but health cost, to having a false positive as a false negative, or vice versa, or getting a true positive against a true negative. And that needs to be taken into account. So we need to weight the value of the correctness or incorrectness of the answer to figure that out. And so I think that's something to keep in mind. Two other thoughts, and then just thoughts for you, Joe. Since this is partly to give some feedback to PCORI. Well, maybe we'll go there first. So for PCORI, one of the things I think this is an area where you have to do observational data, I think. A randomized trial can help you, but it never looks at the range of outcomes that patients and doctors are interested in. The follow-up is always insufficient, because once you have an answer, unless you go to the Joseph Mengele School of Medicine, you have to start your, you have to stop your trial when you've found a result. Things change over time, and you want your model to be updated with new techniques. But the biggest problem I've had, and I've been working the last couple of years with Mike Lauer a little bit, and some people at NHLBI on cardiovascular risk revisited. And the biggest problems are you need good definition of your variables. You need to be able to, missing data is the big killer, And so I think, Joe, from PCORI's perspective, I'd focus on trying to generate registries or observational data sets where there's a lot of emphasis on follow-up, on getting, and several of the speakers noted, getting what happens to the person longitudinally. And the other thing we haven't talked about, and we were just talking about it, was the need for validation, that these things have to be validated clinically. And I'm with Mike. I'm agnostic about the method as long as it as long as it's been validated. And the last thought I have is with Mike's thing, it's really important that that I think PCORI spend a lot of effort on and money on how we present this information. So even in Mike's slide where he showed, you got a multi-attribute outcome set of outcomes here. If one assumes that people know how to treat that information. We know from other people's work, psychologists' work, that if you show a 10% risk and you show 1 box out of 10, 10 out of 100, 100 out of 1,000, that people interpret those very differently. And I'm talking about people like us. I mean, even when you know it, it's like when you flip a coin 8 times in a row and you know it's a fair coin and it's head 8 times, and everybody knows there's a 50% chance of heads the 9th time, but none of us even believe that. If we had to, most of us would bet tails. So I'd say we want to think how we present this information and how it's going to be interpreted by patients, and take into account that the outcomes themselves are going to be weighted variably.
I'd like to follow up that question for the panel by asking too about this issue about longitudinal follow-up. It's not just that patients are different at the outset of the prediction process with regard to either symptom severity or comorbidities or other things, but they change over time. They're not the same 6 months later because their clinical condition has changed. They develop new comorbidities. Treatments have been started and stopped in response to that. The intensification of treatment for the main disease has occurred. And then that happens again 6 months later and a year later. And it's the physician isn't interested just in that initial prediction. The physician's trying to tailor treatment to the patient's evolving clinical course. And Mitch might say, that's confounding by indication at every step along the way. And we've heard yesterday about methods that we're supposed to take into account a lot of this time-varying change in both the clinical condition and treatment changes. So put ourselves back into the position of the clinician and the patient trying to figure out a treatment course that optimizes their outcome. And what are we to do then if you say all of this is confounded data? What are we supposed to do when we encounter that patient the next time they come into the office?
One thing that I've enjoyed in reading Miguel's work and Jamie's is the question, what is the intervention? If you're talking about a prevention trial, you might have a one-shot intervention. Should I take raloxifene or not to prevent breast cancer? Or is the intervention a strategy of initial treatment and follow-up treatment depending on what happens? That could be, if it's well-defined, it can be studied using randomized trials or adaptive randomization. It may not be possible because there's so many options. It may not be feasible to do all the trials, but there is considerable work going on in this area. But I think the question is, what is the intervention we're trying to study, and how best to study it? Now people in the causal community are developing approaches to try to answer some of these questions based on observational data, and to the extent that they do account for confounding by indication and for the longitudinal nature of confounding, they may be getting closer to giving good advice than certainly no access to data. But I think if we can define what we mean by the intervention a little bit more precisely up front, we have several options, including adaptive randomized trials.
Bert?
Yes, Mitch, thank you very much for the, focusing on this, because at least to my mind, the question being asked is one of a process. It's an initial intervention, the long-term follow-up, the adaptive tuning, if you like. And I think the adaptive randomization that you mentioned, yes, I think that's a good start. It's going to get very expensive if it gets done by, if all stages are done by randomized trials. But what I would envision is that the inquiries that would get carried out by the clinician over time would be, if you like, focusing on different parts of a large archive that's out there because the conditions are going to change. And it's not only adding additional interventions, it may be withdrawing some. And there could be substitution along the way. But I think it's this whole adaptive process, that, at least to my mind, that's what we're talking about.
Peter, one last comment on this. and
Yeah,
then
no,
we'll move
super
on.
quick. On the observational side, it is methodologically, exponentially more complicated to model in changes over time. Never mind the confounding issue, just the math part of it. But there's a lot of resonance. This issue of process versus one-time intervention comes up a lot in FDA issues. In oncology, it's quite common to have crossover design. And so you have this intriguing problem where if you look, outcomes are seriously pushed together because of crossover. And the FDA, struggles, as do manufacturers, with, what is the intervention? And everyone sort of plays it to their best interests. But, we have lots of examples where once you cross over people, overall survival differences go away and costs go down because of the sequencing. But the manufacturer's like, if you wouldn't have crossed them over, so.
Next question. Yeah.
This is a web question from John Kai at AstraZeneca. Data mining is more for hypothesis generation versus hypothesis testing, to my understanding. I agree we need clinical trials to validate data mining results if feasible. Can the panel comment on using observational studies to validate data mining results, or using data mining as a pre-step for observational studies by providing sound hypotheses? Especially for CER studies, data mining may help guide investment decisions to ask the right questions.
Nicholas, you want to take that first?
So, absolutely right. The question is absolutely right. So, data mining generates hypotheses. I agree with that. So, no matter where you generate your hypotheses, you have to validate them. And so, it is important to kind of keep the two discussions aside. I was talking about the opportunities that these observational data sets give us in terms of generating hypotheses. And I presented data techniques for trying to generate the best hypotheses possible given the bias in the data set. But I also, and I'll go back to it, presented some validation strategies. That once you have isolated a small number of hypotheses, you can use other observational data sets to then validate them. Those, of course, have their own problems. They suffer from all of the same biases, and so you have to be careful. But once you have that hypothesis, then you go back to the decades-old techniques of epidemiology, you make sure that you're correcting for all of your confounding covariates, and you execute that to the best of your ability and estimate your results. But it's really, so you really do have to separate the two, and I think it's an incredibly powerful technique. I don't know if data mining has gotten to the point yet where it's better than somebody coming up with a hypothesis who is an expert biologist or clinician, but I am working very hard to make it that way.
So it is interesting how words carry their own meaning. Right? We heard that yesterday about efficacy and effectiveness, other terms that are used here. But David Botstein likes to distinguish between what he calls hypothesis-free research, which would be the data mining process, and hypothesis-limited research, which he would refer to as the deficient approach that most investigators customarily take. But the way in which we label those activities carries with it their implications about how we value them.
It's fun because, sorry.
No,
sorry, Peter.
I agree. It's sort of, I think that bucketing is a huge impediment to thinking about this. You just have answers and how much you believe them. Right. And that is influenced by all sorts of things. But, we have studies on clinicaltrials.gov with 28 endpoints, right? And every single one is published separately as an endpoint. And you shouldn't believe any of them.
Right. John.
John Wong, Tufts. Just a wonderful session. And thinking about words, personalized medicine has been co-opted by the genetics community. When I think about patient-centeredness, which is the core of PCORI, and if I think about Steve's questions about where the prioritization should be, I think about this session in particular as individualized risk as being the one that's closest to patient-centeredness. The only part that's missing has to do with values and preferences. And so if I had to pick one of the sessions to focus on for PCORI, it would be this one. My question is for Mike, and levels off of Bert's comment about heterogeneity among physicians, and off of one of my favorite book titles, Predictably Irrational by Dan Ariely, which I would highly recommend. And the question is for Mike in his experiments, where he compares Gestalt by clinicians with the model, whether or not he debriefed the physicians on what they thought after you showed them the results.
So in reverse order, on the breast cancer one, yes. So they saw that analysis. That went from the tool that I was least, that did me the least amount of good to probably the most popular one when they saw that aspect. It didn't work for there. But great, on your first point, that's also excellent. And it also gets to the point of, does this do more harm than good? It's a fair question. Right now we have actually a randomized trial going on, unfortunately, but we've randomized patients to standard of care versus seeing the grid that I show you versus collecting preferences and running through a decision analysis and then following them for regret. All prostate cancer guys to see if there's anything going on there. But I would love to do more of that. That's, it's hard and expensive. But it'd be interesting.
Know about the informed consent for that trial?
Yeah, it's not. It wasn't that bad. It's okay.
Mary?
Mary Charlson Cornell. I actually think we're a lot closer with the collective wisdom here to realizing personalized medicine through individual risk prediction than our genomics colleagues are. It's achievable within a 5 to 10 year window, I think, with the collective wisdom. I think the other window is a lot longer. But I wanted to make one kind of comment and have people talk about. I think one of the things that we have to do to realize the potential of individual risk prediction is to agree on a set of common core elements that are incorporated in all data. Nobody would report data without age and gender. But I think not all of the data sets have socioeconomic status. They don't all have location of residence, which can make an enormous difference. If you're living in Hunts Point, you can't get rid of the asthma, okay, because it's ambient in the air. So I think we need to think about that, and part of it has to have to do with whether people are depressed, whether they're socially isolated, whether they're working, whether they're not 500 things, but maybe 20 items that people collect in a uniform fashion and have available so that as we get to the point of pooling databases from cancer and heart disease, which we should be thinking about doing, because the person with heart disease today is the patient with cancer tomorrow, we'll have the kinds of things that are going to give us power under the hood to explain the variance in patients' outcomes. So I thought it was worthwhile for us to talk a little bit about that.
Peter, you want to comment?
I'll jump in then for you. I think that's a great idea too. It's tricky because I think it's often context dependent, and if we're going to mandate a common core of 20 before you start adding the disease-specific stuff, then it's going to be tricky when the clinicians I work with flinch if it goes over 8 total, unless it's integrated into Epic. But I think if we also, it's tricky because if we reject a model that doesn't have predictors, that's tricky too, because it might put us in, it might be throwing the baby out with the bathwater and putting us into a situation where the alternative prediction system is actually inferior to the one that we think is flawed, and it's a tricky
So let me ask it differently, and actually I was going to ask it of Peter.
Yeah, okay, good.
Is the reason that we don't pay attention in our predictive models to the kind of social, behavioral, and environmental factors that Mary just referred to, because the data are unavailable, as she suggested, because we don't believe that it's really important and is not going to contribute as much as the clinical and other markers of disease are. The same can be asked about biology. We didn't see much biology in any of these models, and yet we know biology is a very powerful influence on the clinical course and outcome of disease. How do we build models that are indifferent to underlying biology? So why are our predictive models so ill-conceived when it comes to both biology on the one hand and social, behavioral, and environmental factors on the other?
The biology piece is harder to answer, I think, and in disease-specific areas, I think there is more. Prostate models have, characteristics of histology and things like that. They're starting to have biology, and certainly a lot of predictive models in, let's say, breast cancer include genetic stuff. So it's in there. I think, first of all, Mary's 100% right. Since sophisticated audience, I can't say 1,000% right. But I think there's a number of challenges. And when I was listening to Mary, I was thinking that, we have been trying to get doctors to put cancer stage into any sort of information that we can get it back out. In a tag on a claim data, into an EHR, stage goes back and forth. They don't, it's a nightmare, and it is the cornerstone of everything they do. And so when I hear about these other things, I think, okay, there's no way we can get doctors, providers to do this. Never mind, we have New York State hospitals reporting that absolutely everyone is one race to discharge date, which is impossible no matter where you are in New York. So I think the future is actually in the realm of patient-reported outcomes and the other sorts of interfaces that are becoming more and more prevalent. We are being able to elicit, we use them some at our institution, we're able to elicit a lot of information from patients that they're happy to give. And that's the sort of information that we should start tapping into, and that's a place where we can have a common platform. And I, as a practicing doctor, am actually glad to have it show up on my desktop, as long as it's not 2 in the morning sort of thing, But I think that's the future. So it's a data problem, but the solution is a different pipe.
So it's interesting because this links back to a discussion yesterday that emphasized the value of getting reports directly from patients, not relying on physicians or other sources of information that may not really address the specific questions that we're interested in. Shelley, quick question?
Shelley Greenfield, UC Irvine. I want to follow up on this discussion and get your reaction to a trial that we're part of in elderly people with basically with no selection in diabetes, all comers. The notion is to get baseline information from the patients of the type that we've been talking about, including depression and other social circumstances, maybe even social support, et cetera. Sorting the patients into risk groups. Peter, you found 4 risk groups that would have been valuable in the early trials, but sorting the patients into risk groups and then tailoring, redesigning the study, particularly the outcome, according to that. And of course, this could be done, as Bert says, in adapting it in the future as well. But I want to ask you what your sense of feasibility and cost and reasonableness is to do that. It's really a combination of using past observational data to sort the groups out and inserting them into large-scale trials. Is that going to be a reasonable approach, or is that just simply too complicated, too difficult, nobody wants to do it?
It's already being integrated. Mitch's models were integrated into prevention trials for breast cancer. And in fact, the lung model, as usual, the Europeans are in a different time zone than we are. And the model I just showed you was used for 2 randomized trials conducted in Europe. So it is happening. It's highly feasible. And in this case, the effect on power of selecting patients based on event probability is just incredibly valuable.
Thank you. Joe?
So Ralph, I'll just say first, I'm going on the calendar that's in the agenda, which says we still have 15 more minutes. Is that okay? Or I keep hearing you say, quick question, and the line is short. At any rate.
I thought the line ended with you.
Joe, I think that was your question, by the way.
It was short. So as we planned this workshop, and particularly this session, I experienced on the planning committee, we jumped back and forth between talking about predicting risk and predicting treatment response. And I had a sense that it could have been very easy to go down the predicting risk pathway because we've been doing it for a very long time and we know a lot about it, and we are currently working on ways to improve it. And I asked myself whether predicting treatment response, especially comparative treatment response, especially predicting in a way that would help a patient say, what's likely to happen to me across a range of outcomes if I choose this or if I choose this. That may just be beyond the pale at this point, but it does seem to me that it's an entirely different enterprise, that predicting treatment response, or particularly comparative treatment response, we're really talking not just about predicting and adjusting for confounding by indication, but we're talking really about interactions then. We're talking about the extension looking for treatment heterogeneity in clinical trials to getting it down to such a refined level that it is really useful to the individual. It's not just male versus female. So this seems like interaction to me, and I wonder, so interaction with what? It's interaction of treatment on the one hand with some set of characteristics of patients that then allow you to say, look, Mrs. Johnson, this looks like you, and for you, this is the predicted comparative response to the two choices you face. And Mitchell mentioned David Beyer, so I'll mention another giant, Ali Miettinen. Before we had propensity scores, we had confounder risk scores. And so instead of combining a bunch of covariates to predict the treatment choice, you combined a bunch of covariates to predict outcome, risk. So you really got people matched on their risk for the outcome, which is kind of what Michael didn't do in a way. He actually did jump all the way to showing individualized comparative effectiveness, but didn't adjust maybe in all cases for major baseline differences in risk between the groups. So might it be possible to, in your predictive model, take care of risk differences through risk scores and then look for interactions with risk scores? It doesn't seem like it would make as much sense to look for interactions with strata of propensity scores, but do people buy the notion that this is an interaction problem and that there may be ways to approach it?
Mitch?
I'd like to show one slide if I could, because I think it may address some of these issues. It's my last slide on this. Let's see. Yeah. Now, this is a slide. It's got an equation, unfortunately, but what is the net benefit in a subgroup? And I'm going to try to get to your point of heterogeneity of treatment effect, but suppose that there are some things, we have a treatment, and suppose we were in the luxurious situation, we've done a clinical trial, so we actually know that the treatment is beneficial. For example, tamoxifen reduces hip fractures, it reduces the risk of breast cancer. So we have some beneficial effects. We also have some harmful effects of tamoxifen. For example, it increases the risk of stroke, it increases the risk of endometrial cancer. Now, the net benefit to a woman with particular characteristics J, this is a subgroup. It might be defined by a bunch of risk factors. So it's a particular subgroup. Well, we might assign different weights to the various health outcomes. So it's the sum over the health outcomes that are favorable of, this is 1 minus the relative risk, so that's how much the risk is reduced by treatment, times a baseline hazard. This is a relative risk. This is the treatment effect for a person on outcome I in subgroup J. And that could vary from subgroup to subgroup if there is treatment covariate interaction. If there isn't, then these things only depend on I, they don't depend on J, and often we just estimate the one, assuming no dependence on J. And then to turn this into an absolute benefit, we have to multiply it by the baseline risk, not relative risk, the baseline risk for that same outcome and that same subgroup. And then we subtract off similar quantities, but since these are harmful, these relative risks will be greater than 1, let's say. And so we subtract off the bad stuff, and we get a net benefit for a person with particular characteristics that puts them in a subgroup J. Now, here's a weight, and it's been mentioned today that one very interesting thing for observational data might be, what weights do people assign to various outcomes? These relative risks, I think, are ideally determined from clinical trial data, if possible, and then you can check for the heterogeneity of them or not across subgroups. But it doesn't matter. If they are heterogeneous, the same idea applies, but you get a lot more precision if there's no heterogeneity in the estimate of the treatment effect. So it may be constant. These things are this is another kind of data that we can learn a lot about from observational studies. Because in order to translate these relative risks into absolute risks, which we're mostly interested in, or weighted absolute risks, we have to know for a person in a particular subgroup what their probabilities of a particular response I would be in the absence of intervention. And we can learn a lot about that, I think, from observational data. And then the one other thing that we learn from observational data is that we learn about the distribution of the risk factors in the population, and therefore we learn about the distribution of these risks, these baseline risks, in the distribution across subgroups. This was mentioned in Peter's talk, for example. So there's a lot that observational studies can do in conjunction with the clinical trial data. I tend to want to rely on the clinical trial data for these treatment effects, but I can see how the observational data, and particularly when we take an average of this net benefit across all subgroups, I can see how the observational data can play a very important role in augmenting the value of the clinical trial data. Now, whether you can get at the detail of the interaction for whether the information is there, whether in the context of a clinical trial or not, I think is an empirical question. Very difficult, though.
So we're staying on the agenda and calendar. We have time for two very brief comments and questions.
Hi, Mark Berger, Pfizer. I've really enjoyed this panel, and I agree with the comment that I think there is more hay to be made in the short term off of collecting this kind of information than there is going to be out of genomic data in terms of understanding heterogeneity. And when we talk about major themes that I've heard here, there's been the hope that electronic medical records could fill in the gaps, but we keep on saying that the medical EMR data is still sparse. But we haven't really fully mined it yet because we're in very early days of using natural language processing to manage the free text notes, and there might be a whole lot more in there. And currently we have a collaborative going on with Humedica to begin to explore that in greater detail. The other comment I'll make is I think rhetoric is important. I think we have to move beyond the idea of patient-reported outcomes to talk about patient-reported measures. And these measures clearly have predictive value. It's a nice paper that was published a few years ago that said when you added the SF12 or the SF36 to standard risk prediction models for healthcare resource use, you could increase the prediction accuracy by about 20%. While I was at a former drug company that I'm not with anymore, we started to collect a standard data set. And we found that that also had a discriminatory power, some of it included in some of the work that Shelley has done with the TIBI. We did not find SCS to be as predictive as we hoped in these small clinical trials. But I do think going forward for PCORI to think about the idea of there being a core data set that is collected universally, not just in observational studies or in registries, but also in clinical trials. I think if we start collecting some core information, we may be able to get it to crosswalk. I'm always reminded by the fact that the single most predictive thing you can ask a patient to decide whether they're going to end up in the hospital the next 2 years is, how do you describe your health? Excellent, good, fair, or poor? And we don't even ask that basic question in every clinical trial. And I think we can, if we start incorporating that, we can pull apart heterogeneity. And I don't care whether it's heterogeneity of treatment course or heterogeneity of response to therapy. It's heterogeneity, and we need to get better separation of signal from noise.
Thank you. So last comment and or question from Bob.
Yeah, this is a follow-up with what Mitch was talking about. Large trials, at least in the cardiovascular area, invariably collect a lot of background and covariate data. Maybe they don't get, good measures of how you feel about your health, but they could. And they invariably show analyses of outcomes usually relative outcomes, not absolute outcomes, but that could be altered in accordance with each of these factors. I mean, that's what the forest plots are, and there are billions of them. One of the things they hardly ever do is look at two covariates combined, old women, something like that. They just look at women and they look at age. But that could be fixed. That could also be fixed. And they also could, but never do, to my knowledge, look at absolute effect size. They only look at relative effects because that's what's easiest to plot on a forest plot. So they could do all that. And those data are largely there. They don't very commonly show anything in the way of major differences, but once in a while they do. But there's really a ton of data on that sort of thing. Maybe people need to look at it more, or maybe it's disappointing that it doesn't show the differences everybody thinks are really there.
That's good, and it should be exploited. But the other potential, though, is that since the selection criteria for entry into the trial change the distribution of risk factors, we could apply the distribution of risk factors in the general population to try to assess what the usefulness of the treatment might be in a more general population.
So that would help you assess the implications of any differences you saw. Yeah. That's absolutely true. It's not as true as people thought that the people who enter trials are all that exclusive. We've taken a look at that, and there are not as many exclusions as people were anxious about showing, although people on death's door don't get into trials. That's true.
So I think one of the interesting things about this session has been it emerged out of discussions that we had yesterday on generalizability and then heterogeneity of treatment effect, and now this individual prediction. But I sensed a different tone to the conversation here than some of the discussion that we had yesterday. Perhaps we were overly optimistic yesterday about in the discussion about heterogeneity of treatment effect and some of the issues about generalizability, although I don't like to think so. Perhaps we were more pessimistic here about the ability to deal with some of the intrinsic biases that worry us about our ability to capture the information about treatment characteristics as well as patient characteristics that influence our ability to really predict accurately. I think this is going to be an area that we're going to have to continue to discuss, because I don't know whether my colleagues feel, but I don't think this one left us with as much precision about the conclusion as we might otherwise have liked. Yeah. So we'll have one more word, which will take us past the scheduled time.
I just had to
attribute it directly to you.
Had to sort of add in maybe a little bit of optimism here. I failed to say in my previous comment that the one slide that got put up, I thought that actually did give a glimpse of predicting in a way that's useful to patients whether they ought to do something or not, was Peter's slide. I mean, he actually did show, and it's important to note that it came from randomized trial data, but predicted certainly in absolute terms, and I think if you look carefully, you can see the relative too, but you recognize the fact that to patients, it's the absolute difference, the absolute benefit that really matters. A nice table that helped to guide patients of different risk levels to whether or not this particular, in this case, a screening test made a difference. So I think the lessons there are that it's really important. It's nice when the comparative effectiveness analyses have been done in a randomized trial. I think perhaps to Mary's point, pooling data is really crucial, and beginning to look for multivariate treatment heterogeneity in those ways, or multiple characteristic treatment heterogeneity in those ways, and then how we present it to patients is crucial.
So I want to, I think that was a very nice addendum. I do want to note that—
Ralph, since this way you
Sure.
get the last word. No, well, first of all, Joe must have been our peer reviewer, but thank you. Just to be clear, the relative effect size of 20% reduction is from the RCT.
Right.
Everything else is from observational. Even though the data we reused may have come from RCTs, it was analyzed in observational context for the prediction of the events.
Right.
So, and that's what Mitch was talking about. That was to determine, I mean, this is a classic Bayesian analysis. So anyway, the priors come from observational data. And then,
But don't you get away from confounding by indication still, if you think from randomized study?
yeah, I mean, right, the effect size comes from RCTs. And as I mentioned, there's been a test for interaction across risk groups, and that was randomized. What the critical variable here, it's irrelevant actually if the relative risk reduction is 10% or 40%. It's the difference impact on patients is based on observational analyses, where we assume that these exogenous exposures are not intrinsic behaviors. Unlike the tobacco industry, we didn't believe that cigarette smoking behavior predicts lung cancer risk, which is what they maintained for a while.
So with that final word, so we really do want to try and get everybody out of here on time today. We do have a break scheduled, but I think you should take the full break to 11:05 because so much good conversation is occurring out in the coffee area where people have a chance to interact. But be back here promptly at 11:05 for the next session. Thank you.